Okay, so one thing is certain, it's not just the female's fault.
In 40% of cases, it's due to the man. So a low sperm count, low sperm motility, too many abnormal sperm.
Smoking is the number one cause of male infertility, correct?
So the body cannot make new eggs.
Infertility is a deeply personal and a very difficult route to conquer. But our today's guest is changing the narrative. Dr. Sulbha Arora, for 2 decades of experience, she has helped countless number of women in their road to successful fertility. So let's dive in. So hello Dr. Sulbha and welcome to the Body Talk.
Thank you so much, Radhika. Pleasure to be here.
So ma'am, there are so many questions that I have around this topic. The whole cycle of conception. I think this is one of the most misunderstood topics by our audience. So if I were to explain the cycle of conception, basically on day 1 or day 2 of our cycle, the small follicles in the ovary, they start to grow. And out of all of those, there's one dominant follicle that is generally chosen, right? It is this follicle that starts secreting estrogen and it builds up our endometrium in anticipation of pregnancy. Somewhere around the day 14th, there is ovulation that happens, and generally the egg stays viable in the fallopian tubes for around 24 to 48 hours. If at that time the sperm comes and fertilizes the egg, only then can conception occur. Is that correct understanding?
Yes.
So ma'am, what do you think are the key disruptors that happen in these phases that affect and cause infertility?
So at every step of the process, there can be a problem or an obstacle that can prevent pregnancy from taking place, right? So first of all, it's the fallopian tubes. If there is a blockage or a damage in the fallopian tubes, then the pathway itself is obstructed. The egg which is released from the ovary will not be picked up and the sperm will not come and meet it. So tubal factors. Then there is the egg and the sperm. So as far as the eggs are concerned, there can be a low egg quality. There can be decreasing egg quantity as we grow older. There can be associated hormonal issues like PCOS. There can be other hormonal imbalances like thyroid problems. There can be problems inside the uterine cavity. For example, scar tissue, fibroids, polyps that can prevent the pregnancy from taking place. There are other problems in the pelvis like, for example, endometriosis that can cause cysts to form in the ovaries, adhesions to form around all the pelvic structures, and even the egg quality can be lower. And what is also important to keep in mind that it's not just the female. The fertility issues can be due to the male as well. In fact, in 40% of cases, it's due to the woman. In 40% of cases, it's due to the man. So a low sperm count, low sperm motility, too many abnormal sperms, and sometimes even though all this is normal, the sperms may still not have the capacity to fertilize the egg because of a high amount of DNA fragmentation. So these are all the reasons why a pregnancy may not take place.
Okay, so one thing is certain, it's not just the female's fault, like it is generally considered in our Indian society. Is the male fertility chance increasing?
Yes, it is increasing. What we have seen over the past few years, I myself, now that I've been practicing for over 20 years, have seen a rise in the incidence of male infertility. But even if you see across the world, about 40 years back, the average sperm count across the world was 100 million. But today, the average sperm count across the world is in the 35 million range. Okay. Now, this is due to the endocrine disruptors in our environment. That's one of the commonest causes because we live in a world now where we are exposed to more than 20,000 chemicals. And these chemicals have an impact on our fertility, on both male and female fertility. Some of them mimic hormones, and we are not even aware that we are consuming these. But we are exposed to so many toxic chemicals now. It's in the air we breathe, in the water we drink, and the food we eat. Yeah. So even if we do try to follow a very, very healthy lifestyle, there is still no escape from this. Added to that, there are lifestyle factors. Because the incidence of lifestyle factors is increasing. Life is becoming more sedentary. So there is a problem of obesity, of high BMI, of stress levels being high. And as a result of that, more and more dependence on caffeine, alcohol,
Correct.
tobacco. So there are lifestyle factors as well which are adding to the problem.
Somewhere I read in a research that smoking is the number one cause of male infertility. Is that correct?
It is one of the leading causes. In a lot of cases, it's idiopathic. When we say idiopathic means, the husband will come and tell us, but doc, I don't smoke. I don't do any of the things you've listed. That is where the environment comes into the picture that I just spoke about. But yes, smoking. So a lot of people are aware that smoking causes cancer, but not a lot of people are aware that smoking affects fertility.
Yeah.
So in the man, it can cause low sperm counts, low sperm motility, too many abnormal sperms, a very high percentage of DNA fragmentation, and all of these contribute to the sperm not being good enough to fertilize the egg. But the other side is also true for women who smoke, because women smoking has also increased, because we live in a world where most women are now working women.
Correct.
So, when in offices, when people are stepping down for a smoke break, the women step down for a smoke break as well. So, smoking doesn't just cause cancer, it affects female fertility as well.
Yeah.
So, women who smoke have got a much faster depletion of their ovarian reserve.
Okay.
The ovarian reserve anyway declines with the passage of time. For smokers, it's even faster. The quantity of eggs decreases faster. The quality of eggs is poor. They also have a higher incidence of miscarriages, of ectopic pregnancies, and of weak babies, of IUGR, intrauterine growth retardation. That means babies who are too small for their gestational age.
So, Dr. Sulbha, you just mentioned premature ovarian failure. Can you elaborate a little bit more on that? Because I think that is on the rise.
That is on the rise. What a lot of people are also not aware about is that we do have a deadline. We have a limited ovarian reserve. People come and ask me, but we've read that you can give us tablets or injections to increase the number of eggs. No, please understand that the number of eggs can never be increased. When we are born with a fixed number of eggs. It's like being born with a 100% charged battery that starts reducing right from birth. It's like you pull out your charger from your phone.
Correct.
And right from that time it starts reducing. It's what happens to our ovarian reserve as well.
Correct.
So the body cannot make new eggs. When we are born, there are 20 lakh eggs at birth, approximately.
Okay.
By the time a girl gets her first period, this is already down to 4 lakhs, because right from birth it starts reducing. When the age is between 20 and 30, it's the age of peak fertility, because the quantity and quality of eggs is the best at this time. After 30, there is a more rapid decline. And between 35 and 40, the ovaries start becoming empty, where we have our last few remaining eggs, most of which may be too weak or too abnormal to give rise to a pregnancy. This is why as we grow older, the chances of conceiving do keep reducing. This is an aging process. We can't stop it and we can't reverse it. But the speed of aging is different from person to person. I'll give you an unrelated example. It's like white hair. It's a part of the aging process.
Correct.
But you see, some people have white hair in the 20s and some don't even till they are 50. So similarly, the aging process of the ovaries is different for everyone. We've seen girls in the 20s who have got almost empty ovaries. That is where premature ovarian failure comes into the picture. And there are times when well into the 30s, women still have a good ovarian reserve. The biological clock is ticking more slowly. So unless we test just going by age, we don't know. But one thing is for certain, since we were talking about the lifestyle factors, see, if we ask in our parents' generation, how old were our mothers when they had their first baby? Most of them will say 20, 21, 22,
Correct.
Probably 25 was too late at that time.
Correct.
But who's even marrying at that age now?
Correct.
That was the age of peak fertility, but the lifestyle has changed. The modern women has so many competing priorities. For today's girls, career and education are as important as it is for the boys. So somewhere in trying to balance that out, we are seeing more and more people marrying late. Instead of being able to marry and plan children in that 20 to 30 age group of peak fertility, people are now marrying in the 30s, people are now marrying in the 40s. So they are marrying at an age where the ovaries have already started becoming empty. Unfortunately, in one generation, this change has taken place, but Evolution doesn't catch up in one generation.
Correct.
Evolution takes millions of years to realize what changes it needs to make.
Correct.
So we are still aging the way our mothers were aging. Our ovaries are aging the way they were aging even then. Probably aging faster because of the impact of lifestyle and environment. And that is why there is an increasing incidence of premature ovarian failure, increasing incidence of people finding it difficult to conceive.
From premature ovarian failure, I remember this incident. So a patient at Nova had come to us. She had told me that, doctor, I got my blood tests and my pregnancy scans done before, and my AMH, which we will talk about, a blood hormone to determine the egg number and quality, was around 2.4. And in 1 year, she said, I do it, and it was 1.12. And she was shocked because she was 26 years old.
Yes.
So this is something which is becoming very common day by day.
It is.
Can you pinpoint a single most important contributing factor?
Environment, like I said. So there is a very interesting book called Our Stolen Future.
Okay.
By an author called Theo Colborn. It's available on Amazon. Everyone must read it.
Okay.
It's an eye-opening book. I read it almost 15 years back. The book was written several years before that. But it's only today that the scientific world has gotten up and started actually focusing on topics like plastics, phthalates, endocrine disruptors, which that book has been talking about for so long.
Correct.
Because unfortunately not enough light was shown on this all these years. But now that the problem has really become monumental, people are focusing on it more. We are forced to wake up and realize about this. It isn't even what we are exposed to. It's what our mothers were exposed to when we were in the womb.
Correct.
So obviously for the coming generations, unless we take action and do something about it, the problem is only going to get worse.
Correct.
So in the area, the book talks about how, in the areas of the ocean where the industrial toxins are dumped, all whales have cancer. In the areas of the ocean where the industrial toxins are dumped, they get concentrated in the bodies of fish, and they have found that birds who feed on those fish, male birds and male birds, have started making nests and living together. Because these are chemicals that mimic hormones, and they cause the constitution to change in a way that there is gender confusion. It's not how it should have been biologically. Because of so much of exposure to chemicals, it's disrupted.
Correct.
And that is why, because of our own actions, that's why the book is called Our Stolen Future, because of our own actions, we are leading towards our own extinction. Everything we do is causing either an increased incidence of infertility or cancer or metabolic, diseases like diabetes, hypertension, young deaths.
Correct.
Recently, India's reproductive rate has fallen below the rate required for a population to sustain.
Correct. Currently, I read, I think Indian infertility rate was somewhere around 15 to 20%.
It is that high.
Yeah, and it is very high. Exactly.
So from 2.1 is the rate, that fecundity rate to sustain a population.
Okay.
That means, for like a couple, if they have 2 children, then the population remains the same. If this falls below 2, if it goes to 1.9 or 1.7, that means a couple is having less than 2 children.
Correct.
So the population is going to keep on reducing as time goes by.
Correct.
And India's population ratio, the fecundity ratio, has now dropped to that level, to below 2.
Okay.
So in the coming decades, we will see a higher number of the elderly population, a lesser number of the young working population.
Correct. So Dr. Sulbha, you touched upon this point during premature ovarian failure, that there are 2 important factors. One is the quantity, another is the quality. So can you talk a little bit more about what is this egg quality exactly?
Exactly. So what happens is that quantity is measurable.
Yes.
There are tests for that.
Correct.
But quality is not.
Yes.
So one thing is that there are no tests for quality, and the quality becomes weaker with the passage of time. It's like, when we are in our 20s, they are young eggs. And when we are nearing 40, those eggs, even if they are normal eggs, are now aging eggs.
Correct.
You can expect a 25-year-old to run a marathon, but it's going to be difficult for a 90-year-old to run a marathon. So similarly, the stamina in those eggs is weaker. Plus, it's not just about that, just the quality. There is also a very important aspect called the aneuploidy rate. Aneuploidy means abnormal chromosomes.
Correct.
So when a woman is in her 20s, let's say out of every 10 eggs being released from her ovaries, maybe 7 or 8 will be normal or euploid eggs. 2 or 3 will be abnormal.
Okay.
In the 30s, this ratio becomes half-half. And nearing 40, or as we cross 40, even if quantities of eggs are still available, out of every 10 eggs that are now released from the ovaries, 8 or 9 are going to be abnormal. And maybe out of 10, 1, 2 or 3 are still going to be chromosomally normal. There is no way to test this. There is no blood test for this. You can test the embryos, but you can't find out beforehand what percentage of abnormal eggs we currently have.
Exactly. So basically, with age, our number is reducing, and even in that reduced number, the quality is also diminishing.
Yes, the quality is also diminishing.
Okay.
So in order to get, one embryo that is going to be successful, that is going to become a baby.
Yeah.
See, because what happens is that every egg doesn't become an embryo.
Correct.
And every embryo doesn't become a baby.
Correct.
So in the 20s, you need less number of eggs to have that one embryo which will give you a baby.
Correct.
Maybe out of 4 or 5 eggs, you can achieve that. In the 30s, maybe out of 10 eggs, you can achieve that. In the 40s, maybe out of 20 eggs, you will have one embryo that will finally become a baby.
And in fact, at 40, that number is only
number
missing.
is not there.
Interesting. Understood. So I think one thing, Dr. Sulbha, that is happening because of increase in infertility, the awareness around infertility is also increasing. So I think now an average woman wants to understand how does she evaluate her reproductive health.
Yeah.
But I think somewhere there's a confusion and they don't know what the starting point is. So could you please guide at what age should a woman start to assess her reproductive health? And what are a couple of tests that she can do?
See, you should ideally test it anytime that the thought occurs to you.
Correct.
Because even in the 20s, we see sometimes women with very, very low ovarian reserve. But if you haven't tested in the 20s, at least when you turn 30, you should do it.
Okay.
Let it be your 30th birthday gift to yourself.
Yeah.
I'm going to check the 2 tests that we normally recommend. One is a blood test called the AMH, anti-Mullerian hormone. And the other one is something called antral follicle count, which we check on ultrasound.
Correct.
So when we do the ultrasound, you can't see the whole ovarian reserve, but you can see the surface of the ovaries and the follicles, which are eggs that are visible on the surface of the ovaries, can be counted. So as the ovarian reserve shrinks, the number of visible follicles reduces. And that gives us an idea about where we stand on this reproductive timeline, how much of time we still have left.
Correct.
So just like we do, our annual health checkups, we do our, cholesterol, blood sugar, hemoglobin, etc.
Correct.
So this annual health checkup or once in 6 months health checkup, at least for those who still not planning a pregnancy, must include their reproductive health checkup as well. Why ignore that?
Exactly. Could you also give us an average range of should this AMH blood test be?
So AMH, if it is say between 2 and 4, it is considered a healthy AMH, which means you are in the fertile zone. If it is above 4, especially if it is above 4.5 or 5, that could indicate that you have PCOS. It's not a confirmatory test for PCOS, but yes, when women have PCOS, we find AMH in a very high range.
Correct.
If this AMH is going below 2 is the time when you must wake up and do something about it.
Understood.
If it becomes very, very low, which means it is now below 0.3 or 0.4, you have reached a stage where now you might be having the last few eggs remaining.
Understood. So basically, AMH and sonography together can tell us a better picture. Is that true?
Yes, that is true.
Supposing somebody has done these 2 tests, they've understood. And if supposing they understand from these findings that, okay, it's now time to hurry up. So, I think we have oocyte freezing as an option. Can you throw some light on that?
So, egg freezing is an excellent option for girls who are not yet planning to get married.
Okay.
It does not reduce your future chances of conceiving naturally in any way.
Okay.
It does not deplete your ovarian reserve any faster. It will remain the same.
Yes.
If you remember, as I was telling you, when we check the antral follicle count, we can't see the whole reserve. We can see the eggs that are visible on the surface.
Yeah.
So to put it very simply, it's like every month from the ovarian reserve, a group of eggs are picked up by the body, recruited and brought to the surface.
Correct.
from where, like you said, one will ovulate.
Correct.
But the others go away.
Yeah.
And next month, again, a few eggs are picked up.
Correct.
So when we do an egg freezing, we just pick up these ones on the surface. We are not pulling out anything from the reserve.
Interesting.
So neither is it going to cause your menopause to happen faster. It's not going to cause your reserve to deplete any sooner. These eggs were anyway recruited. You're just putting them aside for use for your own future.
Exactly.
And you should do it while the eggs are still there. Because this kind of freezes your age in time. Let's say at the age of 32, you decided to put your eggs aside for future. And then you didn't want to or couldn't plan, a start of family till maybe 40 or 42. So fast forward to 10 years later, at a time where your own biological clock might have slowed down.
Correct.
Your chances of conceiving with your own eggs might have diminished greatly. The chances of having a baby with birth defects or miscarriages would have been higher. You might have reached a stage where the only option would have been donated eggs. So
Exactly.
rather than taking donated eggs, why not use the eggs you donated and kept for yourself 10 years back?
Yeah.
So as far as your fertility is concerned, even at the age of 42, you're still 32 because the eggs you're using at that time are the eggs that were frozen at the age of 32. They are healthier eggs.
Correct. Exactly. So tell me something. If supposing a single woman wants to freeze her eggs, is oocyte freezing the only option, or another process called embryo freezing also an option for her?
She can do embryo freezing as well, where she uses a sperm donor.
Correct.
Either a known sperm donor, which is now allowed by law following the proper legal protocol, or an anonymous sperm donor from a registered ART bank, sperm bank.
Okay.
And then you can create an embryo and freeze it. Now, as long as this woman is still single and she wants to then get pregnant and carry the child, she can use these embryos.
Correct.
But say she gets married and then the husband is somebody else and he's not happy to, father a child that came about from somebody else's sperms. At that time, she is, in a difficult situation where she can't use those embryos anymore.
Correct.
So for single women, we usually advise them to freeze their oocytes.
Okay.
If she wants to get pregnant right now using donor sperm, that is legally permitted.
Okay.
But if she just wants to freeze for the future, better to just freeze unfertilized eggs, because then you have the flexibility. At that stage, if you're still unmarried, you use a donor sperm. If you are married, you can use your husband's sperms.
Correct. So also, not many people know about semen freezing. Yeah, that is also an option available for men. So can you throw some light on that?
So for men, men are luckier.
Yeah.
For men, the fertility doesn't decline with age as rapidly as it does for women.
Correct.
So, in very, very, what can you say, common terms or easy to understand terms, what I normally explain to the couples who come to me is that the testes is like a factory. It's going to produce sperms.
Correct.
What does a factory do? There's production happening there. So it's going to produce sperms throughout life. Men can father children in the 70s or 80s also because sperm is still being produced.
Correct.
The ovary is not like a factory, it's like a godown or a storehouse.
Correct.
It can't produce, it can only store.
Yeah.
So nature gave us a deadline. And there was a reason nature did this. Because for a man, even in the 70s or 80s, if he wanted to father a child, what did he need to do? He would have just had to have relations with somebody.
Correct.
Which even at the age of 70 or 80 is not a difficult task for many men.
Yeah.
But the woman has to carry the child. And nature doesn't want the woman to have to do that difficult task at the age of 70 or 80. So after the age of 40, nature gave us permanent contraception, that now you don't have to carry the child anymore. So men don't need to freeze the sperms out of fear of what age will do to it.
Okay.
Although yes, after the age of 45 or 50, the quality can decline. But it's not like it's going to become zero.
Okay.
Semen freezing we do for other things.
Okay.
Like, for example, somebody has been diagnosed with cancer.
Yeah.
And needs to start with chemo or radiotherapy. That is going to make the sperm count become zero. Yes. So might as well first freeze them and then you can start with the rest of your therapies. Then other reasons are there could be other conditions that are causing sperm counts to decline with time.
Okay.
In such cases also you freeze them while they are there. Like for example, there is something called varicocele,
Yeah.
where the blood vessels around the testes get enlarged.
Yeah.
Now this can cause the sperm count to go down, even become zero. So a varicocele surgery can reverse this, but it's better to first freeze the sperms.
Okay.
Because if it doesn't improve, then what are you going to do? Then there is also, for men, there can be, primary testicular failure. Then other cases where we freeze sperms for men is very often we have couples who are undergoing treatments, either IUI or IVF, where the husband frequently travels or he works in a different country. So he can freeze his sperm samples, and then we can use those frozen sperm samples even in his absence.
Interesting.
Once the eggs or the sperms or the embryos have been frozen, they are, they will be in as good a state for as many years as you need to keep them. The duration doesn't affect their quality.
Okay. But I always had this question regarding embryo freezing. We talk about mutation. So does that happen when embryos are frozen in time?
There is a little bit of concern about that, and studies have been done.
Okay.
To see if there are any epigenetic alterations
Correct.
in frozen as opposed to fresh embryos. So far, there doesn't seem to be a significant difference.
Okay, but then actually only time will tell whether
Only time will tell. We will
Yes.
need larger studies. As of now, there doesn't seem to be a significant difference.
Okay.
But
Okay.
in my practice, I haven't seen a problem. In fact, we
Okay.
have so many couples where, because freezing techniques have become so efficient now.
Correct.
If you freeze 3 embryos, you will get 3 embryos when you thaw them. There's almost
Correct.
100% survival.
Okay.
So
Understood.
there have been times where a couple has undergone an IVF cycle, conceived, had some extra embryos frozen, delivered their baby, and then 2 or 3 years later come back
Come back. Second child.
with the same frozen
Correct,
embryos,
correct.
without having to go through another, IVF cycle,
Yeah.
conceive the second baby as well.
Yeah.
And we have so many such stories.
Yeah.
And it's nice to see that, they didn't have to do the whole process again.
Okay. Yeah.
This is the beauty of embryo freezing. I have a couple from Africa who had come down, and in Africa they believe in having large families. They
Yeah.
want to have lots of babies.
Yeah.
And so the first time when she came, she conceived and she delivered a beautiful baby boy. But in her heart, she always desired a girl. Now, of course, I told her in India, we can't do anything about gender.
Yeah.
We can transfer, and rest is up to nature. So when that baby boy was 2.5 years old, she came again. Now, most couples who have a child before, when they are doing another embryo transfer for a second baby, they say transfer 1 embryo because we already have 1 child. We don't want twins. But she insisted that, doc, please transfer 2. I hope to have 2 more. And I hope this time they are girls.
Okay.
So, her prayers worked, or the universe just clicked, aligned along with her thoughts. We transferred 2, and now she has twin girls.
Wow.
So she keeps sending me the
Yeah.
pictures of that boy who is now 6 years old, and the girls who are now, around 3 years old, and how lovely, all of them going to school together. And it's lovely to see families like that.
Yeah. So, Dr. Rao, we spoke about single women and their choices, right? So, if we have to now think about married couples who've now understood either from the men's side or from the female side that it's time to now, start planning pregnancy, I think we basically have 2 options, IUI and IVF. Can you walk us through the differences? The different cycle times, the success rates, which is a very important factor in IVF.
Sure.
So, can you walk us through that?
So, when we do an IUI, firstly, we do some kind of ovarian stimulation where instead of 1, there may be 2 or maximum 3 eggs that ovulate. We don't want more than that.
Yes.
Because we don't want the risk of higher order multiple pregnancy. Correct. But sometimes it's 1, 2 or maximum 3. So now if you have 1 or 2 eggs waiting in the tubes, there is a higher likelihood that if not 1, then 1 will get fertilized.
Correct.
Plus what we do is that at the time of ovulation, we take the sperm sample and we do something called a sperm wash, where we filter it. So we remove the dead sperms, the weak sperms, the debris, the excess of liquid, and we pack all the highly motile sperms into a small volume. We take it in a tiny straw called a catheter, a thin straw, and then we bypass the vaginal acidity, the cervical mucus hostility, and we take all these sperms directly into the uterus and we gently deposit them there. Yes. So now nothing got wasted by leaking out, dying or getting trapped. Instead of just a handful, millions of sperms have now inside the
Yes.
uterine cavity.
And good healthy sperms.
Good healthy sperms,
Yes.
their job becomes easier to find the egg and fertilize it.
Correct.
So this is called IUI. So we have more sperms reaching inside. They're
Correct.
reaching there in an energetic, highly motile state,
Yes.
ready to go and fertilize the eggs. But they still have to find the fallopian tube, find the egg. Sometimes the egg and sperm interaction, the fertilization fails. That is all still left up to nature. So as opposed to trying naturally, with an IUI, our chance of pregnancy increases to about 15 to 20%.
Okay.
It doesn't sound like a lot, but compared to trying naturally, it is almost 3 or 4
So
times
from
higher.
5 to 10, exactly, it's becoming 15 to 20%. Yeah.
Yes. So this is a good option, especially for couples who are young, who have got a good sperm count, healthy fallopian tubes, and a large ovarian reserve, because the chance of success is low, but we have time because the ovarian reserve is good.
Yes.
So in such couples, we could try IUI first.
Yes.
And IUI doesn't necessarily work in the first attempt, as I told you, 15 or 20%.
Correct.
That means in 80% it won't work.
Correct.
It may work in the second attempt. It may even work in the third attempt.
Correct.
Usually, in most cases, we don't recommend more than 3 IUIs.
Okay.
Because if it hasn't worked so far, that means somewhere this is not working.
Correct.
The biggest question mark is the fallopian tubes.
Correct.
Because although there are tests to find out if your tubes are open or blocked, there is no test to find out does that fallopian tube work or not.
Exactly.
It could be a tube that's open. We find out it's open by putting in some kind of liquid through the uterus that then flows out through the tube. So we know that there's no obstruction, but that's one thing.
Correct.
That egg which got released from the ovary, the tip of the fallopian tube has fimbria. They are like fingers. They have to pick up that egg. That movement can't be seen.
Okay.
Could that egg be picked up? Was the tube stuck somewhere? Even if it was free, maybe it couldn't pick up the egg. Inside the fallopian tube, there are cilia. They're fine hair. They move like hair-like structures, like how grass moves with the wind.
Correct.
So they have to push the egg upwards. That movement can't be seen. So we don't actually know that an open tube, is it really a functional tube? So if 3 IUIs did not work, and maybe that is one of the reasons, how many times will we go on trying? What has been seen is that out of all the pregnancies that occur via IUI, 90% of pregnancies have occurred by the 3rd or the 4th attempt.
Okay.
The chances of anyone conceiving in a 5th or a 6th IUI are too low.
Yeah.
Maybe the sperm couldn't reach up to the egg. Maybe they don't fertilize the egg.
Yeah.
There could be so many factors.
Correct.
So this also is in the younger age group. Women who are between 38 and 40,
Okay.
if they are trying an IUI, studies have actually shown that any pregnancies occurring by IUI in this group occur in the 1st or the 2nd.
Okay.
People don't conceive in the 3rd or the 4th IUI at this age.
Okay.
After 40, this number is 1.
Okay.
At the most, you try 1 IUI. If that hasn't worked, then there is no point doing 2nd, 3rd.
Correct.
Another thing that we need to keep in mind when we see these studies, most of the studies are done, in Western countries.
Yes. I think that is the biggest problem about the Indian healthcare data. It's just missing.
We do so much work, but we don't publish as much as we should be publishing. Yes, so another thing that has been now scientifically shown is that there is a racial difference in ovarian reserve.
Okay.
Our ovarian reserve is 6 years less than the ovarian reserve of Caucasian women, which means European or American, any Caucasian woman. The reserve of Indian women.
Okay.
So the chances that a European woman, for example, a Caucasian woman would have of conceiving at the age of 40, we have at 34. So when they say that after 41 IUI works, we need to keep in mind that for our population, it isn't even after 40. It's in the 30s we're talking about this.
Okay.
After the age of 40, I would normally not even recommend an IUI. And this is important for people to keep in mind because they often see celebrities abroad getting pregnant naturally in their late 30s and late 40s. It doesn't necessarily extrapolate to us. There is a difference in their ovarian reserve and ours.
Okay.
So we do try with IUI, but only in cases which are very what we call good prognosis cases.
Correct.
Where the reports all seem to be all right. Then when we talk about IVF, now who requires an IVF? Either in cases where the IUIs have been tried and they didn't work, or in cases where the simpler treatment options don't have a likelihood of working.
Correct.
Like for example, if there is a fallopian tube blockage, there's no way an IUI will work either. If the
Correct.
sperm count or motility are too low,
even
after we have put them into the uterus, they won't be able to find the egg and fertilize it. And then again, in women who have a low ovarian reserve, because an IVF has the highest chance of making a couple pregnant in one attempt compared to the simpler treatment options like IUI and trying naturally. When time is of essence, when we want to reduce the time to conception, we need to go with the method that has got the highest chance. We need to fast track.
Correct.
So what do we do in an IVF is that, remember when I was talking about egg freezing, I said that we only pick up the eggs which are on the surface.
Correct.
So the IVF is done in the similar way.
Yeah.
So there is 10 or 11 days of stimulation to ensure that instead of the one egg that would have grown and the others would have shrunken and gone away, now all of them will grow.
Okay.
And why do we need all of them to grow? Like I said, every egg doesn't become an embryo. Every embryo doesn't become a baby.
We want to increase our chances basically.
Yes. The more eggs we get, the higher our chances of having embryos, the higher our chances of success.
Correct.
So there is 10 or 11 days of stimulation to ensure that they will all grow.
Okay.
Once they have grown, by about the 12th or the 13th day, we do a process called an ovum pickup or an OPU it's called, or an egg retrieval. This is a very gentle procedure. It takes only 5 or 10 minutes. It's done under complete anesthesia. It's called short GA because the anesthesia is required only for 5 or 10 minutes.
Correct.
But the woman is fast asleep dreaming. She feels nothing.
Yeah.
So it's not a painful procedure at all because how do you feel the pain when you're under anesthesia?
Correct.
You don't feel anything. It's not a surgery. There are no cuts or stitches. It's very similar to doing a blood test. Like how we do a blood test, we put a needle in the vein and we take blood out.
Correct.
Similarly, we just put a needle into the ovary and take the eggs out, and they don't even feel the needle because they are sleeping.
Correct.
The process takes about 10 minutes. Once it's done, the woman wakes up. Because there is drowsiness, she rests in the clinic for 2 to 3 hours and then she goes home. It's a daycare procedure.
Correct.
So now these eggs have been retrieved and they are with us under the microscope. Under the microscope, we spoke about the sperm wash, right? So we removing the dead sperms and the weak sperms and the debris and gathering the best of the sperms. And then these sperms and these eggs are combined and kept in the incubator.
Correct.
To grow into embryos over the next 5 days.
Yeah.
When the embryo forms, gently the embryo is placed back into the uterus. The embryo transfer, this is called, is a completely painless procedure. It requires no anesthesia.
Yeah.
So here, number one, we didn't need the fallopian tubes because the sperm did not have to travel through them to reach the egg.
Correct.
They have met outside.
Correct.
Plus, we have ensured that the egg and sperm have met each other and then transferred the embryo back.
Yeah.
So, with an IVF, the chance of pregnancy increases to above 60% in most cases.
Okay. Okay.
So now out of the 100 couples who got married and started planning a pregnancy, let's say there were 100 couples who required an IVF. In most cases, in the first attempt, 60 or 70 would be pregnant.
Okay.
Again, the chances differ based on so many factors. It would be lesser as the woman's age increases. And at younger ages, the chances would be much higher. That's why we tell couples that if you have reached a point where you know that IVF is the next step, then do it sooner rather than later. Even an IVF will work when the eggs are there. It's not going to work when the eggs are gone.
Correct, exactly. Yeah. Also at Nova, I realized that we do something very different, which is ICSI, intracytoplasmic sperm injection.
Yeah.
So, is that a standard across all fertility clinics in India, or is it
so ICSI originally was introduced for male factor infertility, which means where you're doing a conventional IVF, as we call it, these eggs that have taken in the petri dish, there's a culture media, and then the sperms are taken, added to the culture media. Imagine it's like a swimming pool, and they have to swim up to the egg, find it, and fertilize it.
Correct.
The egg is surrounded by a layer of cumulus cells. And just like how it takes place naturally in the body, the sperm has to penetrate through that, find the egg, and then fertilize it. This is called IVF, in vitro fertilization. So, ICSI originally started for cases where the sperm count or motility was too low because there was not enough sperms to even in that dish be able to do this.
Correct.
So, here what we do is that we remove all those cumulus cells gently so that the egg is now exposed. it's uncovered, and then under the microscope, one healthy sperm is picked up and injected into the cytoplasm of the egg to make it fertilize. This is called ICSI.
Correct.
This is the one step that's different between IVF and ICSI. Everything else remains the same.
Correct.
Then the reasons for doing ICSI expanded over the years.
Okay.
So now it is not only for cases where there is, a male factor infertility, with severe male factor infertility. We also find that the fertilization rates are higher when ICSI is done. So there are some clinics who will do IVF and ICSI both.
Okay.
At NOVA, we prefer to do ICSI in the majority of cases.
Correct. Yes. Understood. So the chances further increase.
Yeah,
right?
That's what we feel.
Okay, understood. So I think someone who's we are talking about someone whose own gametes we are using, right?
Yes.
Self eggs, self sperms.
Yes.
But there are a lot of cases now, like we already spoke about the reasons, that either they don't have an ovarian reserve, or probably the sperm morphology or motility or count is not up to mark. They may have to use donor.
Yeah.
So can you throw some more light on whether this donor egg and donor sperm count IVFs, are they increasing more?
With the incidence of requirement of donor egg has increased slightly because couples are now marrying at a later age.
Yes.
But still, with the advances in stimulation protocols, even at advanced stages, we do have reasonably good success rates using the woman's own eggs. And most couples will prefer to use their own eggs.
Of course.
So we do, we explain from our side after analyzing everything, AMH, antral follicle count, what their chances will be using their own eggs and what their chances will be using donor eggs.
Correct.
And then we like the couple to tell us what they are comfortable doing. There is no right or wrong choice.
Correct.
The right choice is what the couple feels comfortable with.
Correct.
So say they were to go with their own eggs or with donor eggs. When we do an ICSI, we don't need too many sperms.
Yes.
If I have 10 eggs, I need 10 sperms.
Correct.
So embryo adoption where both are donated is required not because of the sperm counts being low. That's an entirely different requirement. Let's say, for example, the sperm count is absolutely zero. Azoospermia, even in that case, sometimes the man's own sperms can be used by doing a testicular sperm aspiration, but even that yields no sperms.
Yeah.
Then they might need donor sperm as well.
Okay, understood. So when you see patients come to you, what is the number one concern they have regarding donor eggs or donor sperms?
Well, some part of the concern comes from the fact that it's not going to be biologically mine.
Correct.
So what happens is that even though the egg is donated, let's say it's a donor egg cycle where the husband's sperm is going to be used. So the egg comes from the egg donor, the sperm comes from the husband, so at least 50% of the genetic material is from the couple.
Correct.
But when this embryo is transferred into the woman, over the last so many years of practice, what we have seen is that when the baby is born and as the baby is growing up, we don't find the baby looking anything like the egg donor. And in some cases, the baby may look like the father. In some cases, even like the mother who gave birth.
Correct. So that's
which we used to think is, a great coincidence. But
that's where the science of epigenetics comes.
Yes. Now, epigenetics is a science which says that genes or DNA can undergo changes based on the environment in which they are.
Correct.
That might be the possible explanation about how the baby is looking like the mother who gave birth. So I always tell them that the baby is going to be in your womb. There is going to be a lot of exchange of, so many things between your blood and the baby's blood.
Yeah.
It's not just an exchange of, oxygen, carbon dioxide or glucose. There are a lot of factors that have been shown now that go, immunological factors and all that go from the mother's blood to the baby. Maybe that could be the reason why we see. Plus also it's the way you groom the baby, the way you bring up the baby. So I tell patients that I can assure you that I will get you an egg donor who looks as similar to you as I can. Nobody can assure what the baby will look like because even in natural pregnancies, you have times the baby looks like the father, like the mother, or sometimes like some grandparent or uncle, aunt.
Correct.
And some babies you look at and the family says, God knows who this baby looks like, none of us. So that is all up to nature.
Yeah. In fact, I remember at NOVA, we used to sit down for every patient and actually try to match as much as we could the physical attributes and the blood group both.
Yes,
absolutely. The blood group so that the child later doesn't question. And even the physical attributes like the height, the complexion. So
even the face cut,
Cut,
like you can't
exactly.
find somebody who looks like a replica of somebody. But you know, you have like a woman who has a narrower face or a triangular face, or you know, some people have a broader face. So we do try and match facial features as much as we can, complexion, height,
Correct.
something about the nose or the eyes. Some donor will walk in and I will suddenly remember that she looks like this patient of mine, and
Correct.
then I will want to pair her with her.
Yeah.
We do try to match the physical features as much as we can.
Exactly. So, Dr. Sulbha, does everyone across in all fertility centers do that in India, or this is something that you do?
See, I'm sure a lot of doctors do put in effort, but it's also based on the patient population. Like there may be, a certain like kinds of, let's say, cities or socioeconomic demographics where for the couple having the baby is all that matters. It doesn't matter how much the baby looks like them or not.
Correct.
I have also heard from like other IVF clinics that their patients don't need the blood groups to be matched either.
So this is not a legal...
It's not a legal requirement.
Okay.
It's what I do for social reasons.
Okay.
So supposing a couple is O positive, husband and wife.
Yeah.
If I give them a B positive donor, let's say the baby growing up, or some relative in the family might ask, how is this possible?
Correct.
And the couple might not want to discuss it
Exactly.
from that point of view. Then, like, a few things that I do differently, like, for example, the law allows women up to the age of 35 to donate. But I typically don't take donors above the age of 28 or 29 because 30 onwards, we know the egg quality starts declining.
Correct.
So the minimum age is 23. So most of the donors are between 23 and 29 is what we prefer. Then, like the law, as per law, it's not necessary that it has to be a married woman who has her own child.
Correct.
But I prefer to take an egg donor who has a child of her own, a healthy child.
Correct.
First of all, without that, there is no way for me to know what her egg quality might be like. But if I see a healthy baby, I know that this was possible. Secondly, what I feel is that, see, there is a huge psychological impact. Supposing there is a woman who donated her eggs and later on in life, due to some unrelated reason, could not have a baby of her own. Maybe not related to anything. It could be anything, a male factor. But psychologically, I don't want her to think that once upon a time I donated, now there is a biological child somewhere but not with me. Correct. So keeping all these factors in mind, I prefer to take an egg donor who has at least one child of her own.
Correct. That's amazing. We've now spoken about oocyte freezing. We spoke about IUI and IVF. There's one more thing I want to talk to you about. It is surrogacy. What are the legal conditions happening in India? What exactly, who can opt for surrogacy, who cannot?
So, surrogacy, after the new law came, some of the things that it laid down was that only Indian nationals can undergo it.
Okay.
Only somebody who doesn't have a child before. And obviously for a valid medical indication, like for example, somebody whose uterus is badly damaged, scarred, somebody who was born without a uterus, that can happen. Somebody who needed to have a hysterectomy done for some reason where the uterus was removed and is physically incapable of carrying the child. What a lot of couples mistakenly believe is that if I am 40 plus, I need a surrogate. The uterus does not age as the same way the ovaries do.
Correct.
So if you're 40 plus, it's your eggs that got over. You need eggs. You don't need a surrogate.
Okay.
I also explain this in very simple terms to tell them, for example, if you're going somewhere by your car and your petrol gets over, the car will stop, but you'll fill petrol, the car will stop.
Correct.
Again, the car is not going to get damaged because the petrol stopped. So our uterus is like that vehicle for our baby. The ovaries are the fuel. So if the fuel gets over, the vehicle doesn't get damaged. And just like a car can't make its own fuel, we can't make the eggs. But you add the fuel, your vehicle is fine. So with the passage of time, your uterus doesn't get weaker. There can be other problems that come up with age, like for example fibroids, which is a different thing. But age doesn't impact the uterus the way it impacts the ovaries.
Okay.
So in the older age group, you might need donor eggs. You don't need a surrogate just because you crossed 40. Okay. You need a surrogate if your uterus cannot carry the child. Now, as far as the Maharashtra state is concerned, the center made the ART bill, and then the respective states are supposed to make the state surrogacy board,
Okay.
and give the licenses.
Okay.
In Maharashtra, the licenses have not been given yet. So as of now, we are not doing surrogacy.
Okay. To the celebrities, and this could be a little controversial topic, but if they are fit, how are they then allowed?
I don't think after the new law came in, I haven't heard of any celebrities undergoing surrogacy.
Okay.
cycles.
So previously there was some grey area, and that
There
is.
were the law wasn't there.
So when did the law come?
2021.
Oh, it's very recent.
Yes.
Okay. Understood.
But now after the law has come, I have not heard of it being done.
Understood.
So Dr. Sulbha, we come to a final section, which is the yes. So let's get started. IVF pregnancies always result in multiple babies. True. False. When you transfer 2 embryos at a time, there is a slightly higher chance of a twin pregnancy. But if 10 women conceived by transferring 2 embryos, out of that, 3 will have twins, 7 will have singles. If you transfer 1 embryo at a time, it's a single pregnancy. Okay. We don't transfer more than 2. Okay. IVF babies have a higher risk of birth defects. True or false? False. The risk of birth defects depends on other factors, the main one being the mother's age. So when the mother is younger, whether she conceives naturally or by IVF, she'll have a low risk. When she is older, whether IVF or naturally, it will be a high risk. So it doesn't depend on the method of conception. Babies from consanguineous marriages have a higher risk of defect. That is true. Because when there are consanguineous marriages, generation after generation, there are certain gene defects that get passed on and then amplified. So do you think there are certain foods that actually affect our sperm and oocyte? The main thing that affects the sperm and eggs, as we already discussed, is smoking. But there are also a lot of other things that can take a toll on the general and reproductive health. For example, exposure to too much of chemicals. So if you have too much of processed food, packaged food that contains preservatives, food colors, chemicals, plastics, use of plastics, yes, it can impact your fertility. The natural foods are better. Okay. And the last question, sex position can actually increase chances of fertility. No, it can only increase chances of pleasure.
Thank you for being a part of the Body Talk. If you found this episode insightful, don't forget to subscribe for more such interesting conversations. Also, keep listening to your body because it does talk. Thank you.